Hey everyone, welcome to the Pregnancy After 40 podcast. I am your host, Michelle Johnson, and we are streaming live in the Pregnancy After 40 private group on Facebook. Today we have guest Robert Setton. He's a doctor. He works out of Shady Grove Fertility. Shady Grove has 7 offices across the United States. They are in New York, Atlanta, Florida, Maryland, Pennsylvania, Virginia, and DC. So if you're in any of those states or close by, be sure to look them up. We also have another doctor, fertility specialist from Shady Grove, an upcoming interview and podcast as well. So looking forward to that. So Dr. Setton, thank you for joining us this evening.
You're very welcome. Thank you for having me.
Yeah, so great. So I love your story. And so that's going to be the first thing that we talk about and how you got into reproductive endocrinology. So just tell us a little bit how you got into the specialized field. You went to medical school. You initially were going to be a cardiologist, but you ended up a different way. So just tell us how you got there and how you got to where you are today.
Sure. So thank you again for having me, and welcome to everybody who's joining in tonight. As Michelle mentioned, I'm and Shady Grove Fertility now. I'm in the New York office, and actually will be branching off into Brooklyn as well. I'm a sort of a born and bred New Yorker, born and raised in Brooklyn, did all my training in New York, which is sort of where the story starts in medical school at NYU. I had gone into medical school thinking that I wanted to become a cardiologist. And my trajectory sort of took a turn. As Michelle had mentioned, my wife and I had been married for a couple of years at that point, towards the end of medical school. And we had been trying to start building our family. She was in her mid to late 20s. We tried for about a year, didn't have any success, and then decided to go and have an evaluation. And we found out that at 26 years old that she had diminished ovarian reserve. And we went straight to very aggressive treatments, underwent several cycles of IVF on highest doses of medication, had multiple cycle cancellations, failed embryo transfers, no embryos being developed, sort of a kind of a different array of different sorts of failures along the way. Went to several doctors, were recommended to proceed with donor egg because we had failed so many cycles. Ultimately, on our 6th cycle of IVF, which we thought would be our last, we ended up getting pregnant with my oldest son. And on the day that I saw the heartbeat, I decided to completely pivot. And at that moment, I knew that I wanted to become a fertility specialist because I wanted to help people build their families. Because after so many, such a long time and so many ups and downs and disappointments, to finally sort of reach that moment where I saw that heartbeat, that completely just changed my life. And I knew that I wanted to do my best to do that for other people. Fast forward. So then I went, so I changed my applications from cardiology to OBGYN, did residency at Cornell. And then we decided to build our family a bit further. We did another 7 cycles of IVF, so total of 13 cycles now, and ended up with our twins, also boys. So that's 3 boys now. And this past about a year ago, when we had decided we were done and we were in between different birth controls, and just kind of things just sort of happened. And now I have a 5-month-old baby boy. So 4 boys, all under the age of 6, and haven't looked back. And that whole journey sort of taught me a lot of things. One, obviously, it inspired me and motivated me to go into the field to help people build their families. But it also was very, very humbling in that, the numbers and probabilities were sort of stacked against us. But at the end of the day, we were able to build quite a sizable family. And so it was a nice success story, and it's something that I always think about.
That's awesome. Well, congratulations, one, and on the new
Thank
baby and
you.
all the children. So I want to go back just a little bit. So you stated that at one point, the consideration was using donor eggs.
Mhm.
Was there tests done to the embryos, or was there a reason specifically that you were told to use donor eggs, or was your wife just not getting pregnant just based on her own eggs, and was just kind of like,
Mhm.
okay, we've tried this many cycles, so let's just consider this? Like, what was the reasoning?
Yeah. So multiple reasons. We had tried several cycles. Each of them had failed. The first cycle, there was no fertilization, and the concern that the reason for that was an egg quality issue. Then there was poor response, and the cycle was canceled and converted to an IUI instead of proceeding with IVF because there was only a single follicle to go for. And then the next cycle, when we didn't make it to transfer, that transfer failed, and so the concern was that there was just an inherent issue with the eggs.
Okay. So, was there something different that either you or your wife did between the failed cycles, and then the cycle that actually conceived your son? Did you do anything different? I don't know, just like diet wise, exercise wise, or supplements, anything like that, or did it just kind of just happen?
There was a point where she was supplementing with DHEA and CoQ10, just from things that she had read about online, and some initial studies that had come out at the time. She did get a higher yield of eggs, but the cycles that she was taking that, she didn't get pregnant either. Ultimately, it just ended up being I think by chance, honestly, just that there wasn't anything additional that she was taking during the cycle that she ultimately did get pregnant.
Okay. Okay. So now you are again a reproductive endocrinologist. So, one of the things I wanted to know was, we talk about infertility and how it can plague women 35 and up. So, is infertility defined that you've been trying for a year, 6 months? Are you considered infertile then, or there's an issue with fertility, or is it something that's defined or something that you see when you're actually evaluating a patient?
Mhm. So there are sort of set criteria that we have in place that sort of define or outline what defines somebody as having subfertility or infertility. If you're under the age of 35 and you've been having unprotected intercourse for 1 year, that qualifies you essentially, or kind of puts you in the category of being subfertile and warrants an evaluation. If you're above the age of 35, if you have been trying with unprotected intercourse for 6 months, then that would warrant an evaluation. So those are sort of the two main criteria. In addition to that, if there's something that's known, a known issue. So, for example, if you have very irregular cycles and are only getting a period every 2 months or so, or don't get periods at all, that's something that indicates that you're not ovulating properly, and you don't have to wait a full year of not having a period or having very, very few periods in order to be evaluated. Or if you have already a known diagnosis of endometriosis or something else along those lines, then that warrants an evaluation sooner than those 6 months or 1 year.
Okay. Okay, so speaking of just a couple of conditions, I know you said that your wife had diminished ovarian reserve, and you also just
Mhm.
mentioned endometriosis. So, what kind of treatment and what kind of success do you have with women that have either one of those conditions?
So the treatment and success with both of those conditions can be quite variable. Every single woman is an individual, and we personalize care to that patient's needs. And one of the most important factors that comes into this is the age, because to the best of our knowledge, age is the best predictor of egg quality. The number of eggs that a woman has, whether it's a large amount of eggs or a small amount of eggs that would categorize her as having diminished ovarian reserve, is sort of the other side of that coin. And so treatments will vary depending on what sort of timeline we're working on, just based on their biological age. But also patients have different priorities. I can sort of, when I see a patient and get all their information and see all their numbers, I give them sort of my estimate of what I think their chances are of getting pregnant naturally on their own, getting pregnant using an IUI, which is a sort of a more mild intervention, or with doing IVF. And I can kind of give numbers and percentages and probabilities to that. But at the end of the day, the treatment plan is always decided upon by the patient, because I know how to value certain things, but I can't value their time, and I can't value the cost of things to them. That's something that I always allow patients to guide me on.
Okay. So one thing that a lot of women always want to know is how old is the oldest patient that you've had that has conceived using one of your methods with their own eggs, and the oldest woman overall who is conceived?
So in our practice, for me personally, 44. Our practice, 45, is the oldest, and it's those ages are very, very difficult. The odds are really just not in favor, and it's something that we have to have kind of a long discussion about, and an extensive discussion about, just because even though it is possible, it's important to kind of going in to kind of have an understanding of what you're up against.
Okay. Now, for clarification, is that for a woman's own eggs, or is that overall? That
That's with
age?
her. No, oh, with her own.
Okay. So what is the number? What is the oldest of a woman that you've helped conceive not using their own eggs? Do you know that
Not
number?
so. Probably 50 or
Wow.
49. We actually have, every practice may or may not have also age cutoffs for when they'll do donor egg. At our practice in particular, we set a cutoff at the age of 51. And that's the reason for that is just because as people advance in age, there's other medical comorbidities that they have, and the pregnancy itself can be extremely dangerous for the patient, especially if she has underlying medical conditions. And the mantra in medicine is first do no harm. We want to make sure that the patient is going to stay safe and not have something catastrophic happen to either her or to the baby.
Well, 50, 51, that's awesome. Like, that's just so encouraging, because, we have a lot of women who are over 45 who are in the group, and, they're wondering, is there a chance that they can, have a child? I know the preference is always with your own eggs, but, to know that you can still deliver with donor eggs is still amazing at 50 to me. I don't know if my body could do it. But I mean, I know women are, stay in shape, and, they absolutely can do that. So, and a lot of times when I think of visiting or consulting with a fertility specialist, I automatically think IVF. But IVF is not the only thing that you have for treatment. Can you just talk a little bit about different treatment options for someone that comes to you with infertility or with having issues conceiving?
Sure. So I'm a strong believer in less is more. There are some cases that it's very obvious that IVF is needed, and it's very easy to sort of sell IVF in a way, because no matter what, IVF is going to be the most efficient way of getting pregnant. So if you sort of pitch it that way, that the best odds are with IVF, it's very easy to sort of go that route right away. My personal belief and the way that I practice is sort of is the less is more philosophy, and sort of stepping up with different time frames based on when the step up should happen, which is often dictated by the age and markers of ovarian reserve. So some of the ways that a reproductive endocrinologist can help is sort of the most minimally invasive way is with natural cycle monitoring. So essentially what we do is we bring the patient in we don't give them any medications, allow them to ovulate on their own, and we sort of follow the process of the follicle developing and the egg developing. And when it's ready, we either allow the body to surge on its own, or we can give a medication to optimize the surge and the ovulation of that egg. And the reason to sometimes give that what we call a trigger shot in order to kind of set off the final egg maturation and release the egg is so that we can kind of have better timing for when the patient is going to be intimate with their partner. So doing natural cycle monitoring with timed intercourse, it sort of allows for better timing of things that way, as opposed to waiting for the natural surge, which sometimes can be missed. Sometimes we need to support the second half of the menstrual cycle with some progesterone, which is just a vaginal pill, just because progesterone is essential in the early part of the pregnancy. So natural cycle with timed intercourse is route number one. Natural cycle with an IUI is another route. In that case, what we do is, again, just follow in a natural cycle and allow the natural process of ovulation to happen, or give an injection to sort of time things more appropriately. And then we do an IUI, or an intrauterine insemination, where basically what we're doing is we have the partner produce a sample that morning. We then take that and process it and wash it, sort of get rid of all the not good stuff and leave only the good stuff. And then we take that, put it into a catheter, and then in an exam that's kind of similar to a pap smear with a speculum, that catheter is then placed into the uterus at that time when ovulation is happening, in order to kind of get the sperm in a closer vicinity to where the egg is, to try to maximize a high number of good quality sperm next to that egg. The next route that we can take is by giving medication. And there's different levels of medication that we can give. There are oral medications, and then there's injectable medications. There's two types of oral medications that are generally used, that many people may have heard of. Clomid is one that most people that have started this journey have heard of. Letrozole is another. And the goal of those can be either to induce a single follicle or a single egg to mature, and then you can then have that egg ovulate and have intercourse, or do the IUI, as we mentioned previously. Or the goal of that would be to have multiple follicles grow. And that's often a strategy in unexplained infertility, or in patients who are older, where we're worried about the egg quality. And if the idea there is that if we do what's called superovulation, where we have multiple follicles growing, 2 or maybe 3, and then have either timed intercourse or have an IUI, that we can increase the chance of pregnancy for that cycle by allowing the body to release more eggs. Those are essentially the steps that we can take prior to IVF. The last part prior to IVF is doing injectable medications, which is giving the hormone called FSH, and that's the same hormone that the brain produces in order to tell the ovary it's time to grow a follicle or grow that egg. And we give that injection, and that's taken daily during the early part of the cycle. And the goal then, again, is to have multiple cycles, eggs develop, but that's only something that's done in a select patient population.
Okay. So in this group, as you know, it's over 40. So time is really of the essence. And so a lot of women are anxious because of their age, and time is kind of ticking. So I want to go back to one question. I know you said that you monitor cycles initially. What is the minimum time that you monitor cycles, or is that contingent upon the age of the woman?
So it's contingent, one, upon the age of the woman, and it also depends on the amount of time that they've already been trying to conceive on their own, because that information is critical. Because some people will come as they just got engaged or just got married, and they want to try to start, but and they're nervous because they know that with advancing age there's difficulties, and they haven't tried on their own yet, or have only tried for 1 or 2 months. In those cases, I will sort of start with just sort of the natural cycle monitoring, and we can always sort of bump things up with an IUI very easily. And I would recommend IUI in those cases, just because they're coming to me for help, or to try to improve the chances or bump up the chances as quickly as possible. But I often will set a limit on that. So 3 is the general rule of thumb. With being less aggressive before bumping up to being more aggressive, because again, time is of the essence, and Another important factor that also has to be considered is what the ultimate family size that's desired. Because if someone is coming at 40 years old and wants to have 2, maybe 3 kids, then the only way to sort of make sure that there's a good chance of having more than one child is with IVF and banking embryos. Because when you do IVF, you get the goal is to get as many embryos as possible. You get as many eggs as possible, fertilize those, and then grow them out. You can, hopefully you do a transfer of the embryo that's sort of leading the pack there. And if that pregnancy works, then fantastic. But then you potentially can have several embryos that are in the freezer that are there waiting for when you're 43 years old or 45 years old and want to come back to try for the sibling.
Okay, so I'm going to go quickly to a question that I see that came up in the chat, and it's at 43. Is Clomid a good option when I already ovulate regularly? And before you answer that, I'm going to say, so in the group, the discussion of progesterone and Clomid is huge. So are those 2 things that women should take or possibly take before they even come to you, or should they get the approval of their OB before doing that?
So I always feel more comfortable having patients come to me sooner rather than later. There certainly is a role for the general OBGYN to be doing Clomid, to be giving progesterone, but when you're above the age of 40, I think it's always prudent to be seeing a reproductive endocrinologist, just to make sure that those initial cycles where we're trying to do things with less interventions are sort of optimized to the greatest degree possible. Just because a reproductive endocrinologist has the bandwidth and the resources to kind of have more frequent monitoring, real-time ultrasound, blood work that's back the same day, that general OBGYNs just aren't equipped to do. So now, to answer the question about whether or not Clomid, there's a role for Clomid, there certainly is. And the goal would be to increase at the age of 43. There's a substantial number of eggs that will be abnormal, and that's sort of the greatest obstacle that has to be overcome. And so with Clomid, the hope is that you basically are going to trick the body into allowing multiple follicles to be released, with the idea being that if you increase the quantity of eggs that are being released, that there is going to be hopefully one of those will have a normal number of chromosomes. Again, and then the discussion about how often to do that is something that needs to be personalized. But there is, I think that it's good to go in with sort of a limit in your mind as to how many times you're willing to be trying that.
Okay. So I can't see the person who actually asked that question. It just tells me Facebook user. But so I'm not sure if you're the one who asked the question, if you have already seen a reproductive endocrinologist, you started taking it on your own. But I'm going to ask you, Dr. Setton, what about the progesterone? Because again, I've heard that a lot, just in the group, and women have taken different types of progesterone. Some take it orally, some insert it vaginally. So what is your take and advice on progesterone dealing with women over 40?
Sure. So in order to sort of think about the role of progesterone, it's important to kind of understand where this is coming from and what the thought process is behind it. So in a natural cycle, the way it works is that the brain sends signals to the ovary with FSH, telling the ovaries it's time to grow the follicle. That follicle has the egg in it and will continue to grow and mature until the time of ovulation. Time of ovulation, the egg is released. And at that point, the follicle that had the egg in it now turns into what's called a corpus luteum cyst. So it's a cyst that kind of sits within the ovary, and very rapidly, it's quite amazing. It undergoes so many changes that that follicle, that cyst, is now, in addition to producing estrogen, which it had been doing up until now, also starts to produce progesterone as well. And the progesterone is very important because these hormones, the estrogen that's being produced by the follicle and the progesterone that's now being produced by the corpus luteum, are talking to and sending signals to the lining of the uterus. So in the beginning part of the cycle, when that follicle is growing and estrogen levels are rising, the lining of the uterus is thickening. Now, when progesterone is introduced, it causes the lining to undergo a process called deciddualization, which is basically changing how the lining is morphologically, chemically, in order to open up a window of implantation, a window of time, a certain sort of create itself in a way so that it will match up with that embryo and allow the embryo to stick in the uterus and grow. Progesterone also is essential to the growth of the early pregnancy. And the corpus luteum, or that cyst that's formed from the process of ovulation, is going to be the primary source of both estrogen and progesterone and maintaining the early pregnancy until the placenta can take over, which happens somewhere around the 7th week. So when we talk about the need for progesterone in a cycle and the type of progesterone that we're giving, it really depends on what's going on in the first part of the cycle. So if the ovulation process is optimized with, say, Clomid or letrozole, giving a trigger, things like that, then the role of progesterone is different than say, or the need for progesterone is different than it is, say, in an IVF cycle. Where there's multiple follicles growing and there's a needle that goes into the ovaries and sort of disrupts the follicles themselves. So there's different flavors of progesterone. There are the oral pills, there are the vaginal pills, there's the intramuscular injections, are sort of the main categories. Typically with the progesterone pills is something that I tend to not use, just because the absorption isn't as good as when it's given vaginally. And the progesterone pills often can be inserted vaginally, and the absorption is much better and has more direct access, basically, to the uterus, just because it gets absorbed at the local level. There really is no need for intramuscular progesterone unless you're in a situation where you really need to maximize progesterone to the greatest degree possible. And that's often done in a frozen embryo transfer, or in a cycle where there is no corpus luteum, where there isn't that cyst, which often happens with a frozen embryo transfer, and in IVF cycles often. And it also depends sort of on the way that you were triggered and sort of different parameters within the cycle. But in those situations, intramuscular progesterone is quite important, particularly in the beginning part. Now, a lot of issues do come up with intramuscular progesterone. There are, and I've seen time and time again, pain at the injection site, neuropathies, infections at the injection site, and so we have to switch it out and either use different. It can be mixed in different types of oils and things like either switching the oils or the caliber of the needle, or just switching to vaginal progesterone completely. But there's definitely good evidence for the need for progesterone in frozen embryo transfer cycles, in IVF cycles with a fresh embryo transfer, and when using gonadotropins, meaning the injections with an IUI. The role for vaginal progesterone in a natural cycle, or in a Clomid cycle or letrozole cycle with either time intercourse or an IUI, is quite limited. And it's often, honestly, just given anecdotally, just to sort of make us feel that we're doing as much as possible to increase the chances of the embryo of the pregnancy continuing.
Okay, so is there a disadvantage for women to start taking the progesterone, just to say orally or they insert it vaginally. Is there a disadvantage to them starting to take it now? Again, because I hear a lot of it and I see a lot of posts in the group. So you just kind of, want to give that information as well. Will it hurt them to take it before they started seeing a specialist?
Right. So it won't hurt. The one situation in which it can hurt is if the timing of it is too soon, because as soon as the body starts seeing progesterone, that's when the lining of the uterus starts to undergo those changes, and it sort of sets in the time frame for the window of implantation. So that's why it's important to do this in conjunction with your OBGYN or with a reproductive endocrinologist, just because you don't want to be starting the progesterone supplementation too early, because you may shift the window of implantation to a time where it's not actually synchronizing with the age of the embryo itself and when the embryo is able to implant. And by the time the embryo is ready to implant, the window may be shut if the progesterone was started too early. That would be the only downside, I would say. Other than that, there isn't really much of a downside at all.
Okay. So just for defining purposes, you mentioned earlier again that your wife had diminished ovarian reserve. Is that the same thing as diminished eggs, or is that something different?
I'm not sure what's referred to by diminished eggs, but I think it's probably pointing to the same thing. A diminished ovarian reserve refers to a reduction in the quantity of eggs that a person has.
That's what I meant.
Yes.
Okay. Okay. And then can you also tell us exactly what endometriosis is? And if someone came in with endometriosis, at what point do you start, like, what level do you start treating? Do you take, like, do you start monitoring, or do you go to stage 3, or where do you start with a person with endometriosis?
Gotcha. So first, to define endometriosis. Endometriosis is a chronic inflammatory gynecological condition, and it's a hormone-dependent condition. So what I mean by that is that it's a process that stays there. It's defined again as by a state of chronic inflammation, because of that, associated with pain. And it's hormone dependent. So it depends. That sort of is the backbone of how we treat things. And the hormone specifically that is dependent on is estrogen. And so a lot of our treatments sort of focus around that process. And it really it's a condition that's associated both with pain, very often extremely painful periods, and often pain with intercourse as well. Those are sort of the two main presenting symptoms of endometriosis. And in terms of where you start with treatment, depends on what you think the stage of endometriosis is. So there's sort of it's classically divided into 4 different stages: stage 1, 2, 3, and 4. Stage 1 being the most mild, and stage 4 being the most severe. And with and the approach to management sort of is different with stage 3 versus stage 4. Firstly, it's important to note that the only way to definitively diagnose endometriosis is with surgery and pathological confirmation of endometriosis. That being said, there are some nuances to that, of course. If there are certain exam findings that can be highly suggestive of endometriosis. So, for example, if you see an endometrioma, which is a cyst of endometriosis that's found within the ovary, that is highly suggestive of it. If on exam there are certain features on exam that are also highly suggestive of endometriosis, such as nodularity on the pelvic exam. A fixed pelvis is also associated with endometriosis, because what actually is happening with endometriosis is, we spoke a little bit earlier about the lining of the uterus. So there are certain cells that are only supposed to be within the lining of the uterus, called the endometrium. And when some of those cells migrate out or are existing in other places, such as on the side walls of the abdomen, or on the ovary itself, or in the bowel nearby, that's what's causing endometriosis. It's basically the presence of tissue that it should only be within the uterus is found outside the uterus. And so treatment often depends, one, on symptoms. If patients are very symptomatic, having severe pain, and there's evidence on imaging or exam of having stage 3 or 4 endometriosis, oftentimes surgery is needed in those patients in order to sort of optimize them prior to initiating treatments. Another thing that we see often with endometriosis, which also may warrant surgical intervention, is that it can cause a distortion of the pelvic anatomy. And that's because this tissue that's outside the uterus can sort of cause adhesions or abnormal connections between different things. So the fallopian tubes might be kinked or might be blocked because of extrinsic factors that are causing that have caused essentially the equivalent only of scar tissue within the pelvis. And so surgery is sometimes needed in these patients. If there is evidence, alternatively, without significant symptoms of pain, but finding of evidence of stage 3 or 4 endometriosis, the recommendation in those patients is actually to proceed more aggressively with IVF. And the reason is that several studies have looked at in those patients that are sort of on the more severe side of the spectrum, that expectant management or doing Clomid, IUI are not very effective, and the best way to achieve a pregnancy is with IVF. So those are the only cases where I proceed more aggressively. Something obviously that also has to come into the equation is age. Someone who's 25 with stage 4 endometriosis, I approach differently, and will be may be less aggressive than someone who's 38 or 42.
Okay. Okay, so before we get to questions, I'm going to ask about male infertility.
Mhm.
One, how often is male infertility an issue in conception, and what are the different types of male infertility, and how do you treat those?
Sure. So men do not get off the hook here. Male infertility or male component is implicated in 40% of cases of infertility, which is
Wow.
which is very high. It's very, very high. Oftentimes, now when I say that, it's with the caveat that sometimes is in conjunction with a concurrent female component as well. But but regardless, a male component is present up to 40% of cases, which is pretty significant. So how do we sort of assess the male? It's as opposed to the workup that's done for the female, which is quite intensive and a bit more involved and cycle dependent, and and things like that. For the male, it's relatively straightforward. Our initial screening test is a semen analysis. And in the semen analysis, the requirement basically is that the male is abstinent for anywhere between 2 to 5 days. A sample is produced, and that's analyzed, and we look for certain things. Mainly, what we're looking at is the concentration of sperm that's present within the sample, the motility of the sperm, and how well the sperm are moving, and then thirdly, the morphology of the sperm, or the shape of the sperm itself. And we want to, there are certain parameters and cutoffs that we look at for that, and that's just sort of the basic screening. If there are any abnormalities that are seen, the recommendation from the American Urological Association is to repeat that semen analysis about a month later, just to sort of see if those abnormalities persist or not, because there are many things that can affect a semen sample in the sort of at any point in given time. If the male, say, had a recent illness, fever of some sort, that can compromise semen quality. If there's other sort of chronic inflammation going on, that can affect certain medications, can affect the semen quality. Certain lifestyle habits as well, smoking, marijuana use, can all sort of affect these things. And if there is an abnormality seen, that's not a very drastic abnormality, that needs to be confirmed with a repeat sample. You asked also about different treatments that we have for male infertility. So it sort of depends on the etiology. If there are some with sort of more mild cases of male factor infertility, that can be overcome with an IUI. And because, as we mentioned before, with an IUI, we're taking the sample and we're doing a special wash for it and allowing sort of the good sperm to be separated out from the bad sperm. And we do, prior to the wash, a sperm wash, and after the sperm wash, we do that other assessment. Again, where we look at the concentration, look at the motility, to see if the parameters are significantly improved or not. So oftentimes with just a mild male factor, with just subtle, borderline changes in the semen analysis, we can overcome those with an IUI. If there are more substantial changes in the semen parameters, we may, and with male factor infertility, oftentimes the next the treatment for that would be ICSI, or intracytoplasmic sperm injection, which is a process that's done with IVF. So there are cases where we have, certainly cases where we have female with absolutely no issues on our workup for a fertility evaluation, but the only issue is that there's a significant male factor, and in those cases, unfortunately, what we have to do is do IVF and get egg and do the stimulation and do the egg retrieval for the woman, get those eggs out, and then what we do is we pick up under the microscope, pick up one little sperm and into a needle and directly inject that into the egg in order to achieve fertilization. And that is sort of a big revolution in the field that happened probably 25 years ago now, and has really changed our ability to treat most men with male infertility. The sort of next step beyond that is there are cases where sperm is not produced at all, or extremely, extremely, extremely limited amount of sperm. And so, in order, obtaining sperm from an ejaculated sample is something that's not sometimes possible. And in those cases, we have to extract sperm, and that's done with that's done by a reproductive urologist. So the same way that I treat female infertility, we have sort of our male counterparts, and they step in and get involved when there are surgical interventions that are needed or other medical interventions that are needed in order to improve sperm parameters. And they can perform a procedure where sperm is directly extracted from the testicle itself, and that can then be used in an ICSI cycle.
Okay, so I'm just absolutely amazed at all the technology that is involved in the reproduction cycle. Like I applaud you. That's a lot.
It's super cool. It blows my mind every day, and the fact that we can do this is it's just amazing. It's a miracle of modern medicine. It really, really is. And we've only, and of course, the more we know, the more you realize that you don't know, and the more there is to learn. And we just have to keep, pushing through and advancing.
Amazing. Yeah. I thank you for doing that. Doing all that you do. So, okay. So I'm going to ask this question. How important is the diet and exercise of the male in trying to conceive, along with the woman?
Great question. And there actually has been, in one of our main reproductive medicine journals, there was a recent debate about this, because it is a subject that is debated. So I'll backtrack for a second. No one would argue with the fact that having a healthier lifestyle and avoiding sort of toxic habits are good for your overall health. There's sort of an anecdote that when the body is in sort of is in stress or under duress, that the first organ system that would shut down is the reproductive system. And that's it's something that we see certainly with females, and it's something that we see with males as well, just because it's sort of almost an evolutionary process that sort of takes over, where if it's not an ideal time to reproduce because there's a toxic environment in the body, because you're not getting enough food, because you're not, in a healthy condition, that it's probably not a good time to be reproducing, because going back to ancient times, it means that there's not enough food to provide for the baby when they're going to come. And so we see even in females in times of extreme stress that the body shuts down and ovulation stops, which is incredible. And there's a similar, it's not as robust, but similar things can happen with men as well. So we had already mentioned that being sick, having fevers, can compromise the sperm quality. There's sometimes different conditions, medical conditions that are chronic medical diseases that are picked up because the semen analysis was done and there's something abnormal, quite abnormal. And so they go to a reproductive urologist for an evaluation, and it turns out that there may be cancer or something, or something else going on. That's more of a rare situation, but it certainly is something that we've all seen on occasion. And now, in terms of supplements and things like that, there sort of has been a lot of debate about the role of antioxidants for management, for improving male fertility. The idea being that one of the things that can affect the ability of sperm to lead to a successful pregnancy is the integrity of the DNA within the sperm itself. And the DNA sperm integrity can be compromised when there's a state of oxidative stress or the presence of what's called reactive oxygen species. And the way to counteract that is with antioxidants. The issue is that when we see that patients have high levels of sperm DNA fragmentation or abnormal DNA within the sperm, they're treated with antioxidants, it doesn't really change things too much. And it's probably just because some of these supplements just aren't, they just don't get absorbed in the way that it kind of gets to where it needs to go with the doses that we can safely give. So that being said, a multivitamin is 100% beneficial. Antioxidants, there's question mark, but probably not. But overall lifestyle habits such as marijuana use, smoking cigarettes, all those things are not good for your overall health and not good for your semen quality.
Okay, great. Okay, so what are ways that you kind of mentioned men, but what is the way or some ways that women can prepare themselves physically and even mentally and emotionally before they actually even come to a reproductive endocrinologist? Like, what are the things that they can do beforehand?
It's a great question. So one thing that I think, in terms of, let's talk about physically and both emotionally, which are both very, quite difficult things. Physically, you want to try as much as possible to sort of reach your ideal lifestyle situation. So having a well-balanced diet, exercising regularly, but not too much. And if you're underweight, trying to gain weight. If you're overweight, trying to lose weight, and try to get into a sort of a normal BMI category, are things that you should strive for. Anyone who's trying to conceive should 100% be on a prenatal vitamin. That is extremely, extremely important. Very, very, very often. We have people coming in who aren't taking prenatal vitamins, even though they've been trying for a long time. But it really is essential. It helps with sort of everything that we do, and is also critical for ensuring that the neural tube or the spinal cord of the baby will close properly. And then review if you have any other medical issues or medications that you take. It's important to review that with either your OBGYN or your primary care physician when you are deciding that you're going to try to start conceiving, just because if you're on certain medications, say for blood pressure or for other issues, there may be certain medications that you're taking that are either that either can impede the process of getting pregnant, or it can cause harm to the baby. And I think that's an important thing that people need to remember. In terms of being emotionally ready, you know, I know what it's like to sort of be at the other end of the table, just from going through things with my wife, and of course I only see it from I only saw it from my perspective, which is as my wife's partner, as the husband. So I can't feel what she feels, but I can sort of see that and empathize that. And I know nobody wants to be going to the doctor for help getting pregnant, and it's something that I always remember, and I recognize, and I know it's a very, very vulnerable time in your life. And at this point, you may have been trying for several months, and it puts strains on relationships, and it puts strains on your within you and your partner, and also with family members or friends, or whatever it is that are sort of kind of giving you get different pressures or comments and things like that are said. I think it's just with knowledge is power. I think it's always good to try to read up and understand what the process is going to be. I'm not saying to Google things, because that's going to probably just scare you more than it needs to. But there are some credible sources out there that can give you a bit more of a realistic baseline knowledge of what to expect, and of what the potential issues and treatments and things like that may be. ASRM.org. The American Society for Reproductive Medicine, which is sort of the governing society for reproductive endocrinologists, has a pretty good amount of patient information that I think is helpful just to sort of browse. It's always helpful, I think, to sort of be familiar with some of the terminology that you'll hear your doctor use, and just kind of have an overall feel of things. There are certain places on the internet where or in social media that are sort of good to go to, but some that can be a bit toxic and a bit and maybe a bit harmful. I think it's important always to be positive. We're optimistic, we're cautiously optimistic, but always optimistic. And I think it just sort of try to gauge yourself and prior to meeting with your physician. Know that you're going to get a lot of questions about your cycles. Know that one of the initial parts of the evaluation is having a vaginal ultrasound as well. And there's probably going to be a lot of ways that you may be disappointed. There's only one way for your doctor to make you happy, but a lot of ways to disappoint, unfortunately. And so I think just sort of setting your expectations, but it's very hard to do. But it's something that I think try as much as you can.
Well, that is great information. I'm going to go to a couple questions before I let you go. Oh, let me just confirm. ASRM.org. Is that what you said? Okay. We're also going to put that in the show notes as well. So one of the first questions we received was, what are signs with your period that age is starting to show? So I'm going to assume that kind of means like you're getting older and there may be some changes in the monthly. So can you answer that question really quick?
Sure. So the first sign of that is actually shortening of menstrual cycles. So an average cycle length is 28 days, but everyone is a little bit different, and sort of within the normal limits of what we say is between 21 to 35 days. But your normal is your normal. The first thing that happens, or the first sign, is that the menstrual cycles start to shorten. And the reason for that is because the body has to try harder in order to get that egg to grow. And so the egg will start to grow actually before you even get your period. And so the ovulation will happen earlier in the cycle. Once ovulation happens, a period comes 14 days later, no matter what, if you're not pregnant.
Okay. So then the next question.
Sorry, and then later on is when the periods start to space out when entering the menopausal transition.
Okay, so if the periods are shortening, meaning they're closer together now. So now they're
Mhm.
like maybe 26 days and they used to be 29 or something like that.
Yeah,
Is it
even less.
okay, really? So is
Mhm.
it at that point that they should go ahead and probably consult with a specialist?
Yeah, yeah,
Okay. Okay.
absolutely.
So we have Vero who stated, I'm 40. I have a fibroid, 4 embryos. I'm waiting for FET. You know what that is? I don't.
Frozen
Um,
embryo transfer for the audience.
okay. And I don't know. Can you see the question
No, I
on
can't
your
see.
okay. So my lining is all over the place and sometimes try
Trilaminar.
yes, and
Yeah.
sometimes not. What can be done? I will be having hysteroscopy,
Hysteroscopy. Yeah.
hysteroscopy. Okay, this cycle. I started this journey back in August of 2020. So she's asking what can be done with her lining being all over the place.
Right. So fibroids present sort of another challenge. Saying that it's trilaminar sometimes and sometimes not. It sort of depends on the size of the fibroid and the location of the fibroid. Because in certain positions, there are certain angles that you can only get with an ultrasound, basically, and sometimes you'll be able to catch it as being trilaminar, but sometimes the angle is just such that you can't really appreciate a trilaminar appearance. Um, and that's and you probably have seen from doing multiple ultrasounds that things look a little bit different each day, and things angles, and some ultrasonographers take more time to get the proper angles and things like that, and that's because you have to remember that the uterus and ovaries are sort of existing within your body, and it's a dynamic place. There is bowel that's coming in and out. The intestines are naturally moving in front of it and behind it and to the side of it, and so all these things can sort of change the angle that your uterus is at that morning when you go in for your ultrasound. And so there are times when, you'll see something as being trilaminar one day, and the next day you're not seeing it, or vice versa, and you're sort of scratching your head as to why. And it's most likely just because, particularly with fibroids that sort of change the anatomy a little bit, it's just hard to appreciate it on an ultrasound. Doesn't mean that it's not there. Um, the important part about fibroids is whether or not it's encroaching into the cavity or if it's abutting the cavity. So it's if the fibroid is within the cavity, or it's there, that has to be removed. And it could be done hysteroscopically with the procedure that you're going to be having. Um, if the fibroid is what's called intramural, and it's only within the muscle of the uterus itself, so this is actually another area that's sort of hotly debated, whether or not that's something that's worth removing or not in order to optimize chances of a pregnancy. Um, Many studies are inconclusive. The most important part is whether or not it's causing that fibroid that's in the muscle is causing a distortion of the cavity or not. Because you may have not all intramural fibroids are created equal. Some will be present, but not sort of impinge the cavity or compress the cavity, but some will. And so a hysteroscopy is a good choice because it's an allowed direct visualization of the contour of the inside of the cavity, in a way that can be appreciated more than on ultrasound imaging, such as a saline ultrasound or something like that. Particularly if it sounds like it may be difficult to get the right angles with an ultrasound. But direct visualization with a hysteroscopy, which is a camera that goes into the uterus when you're under light sedation, would be that's definitely a good first step. And having 4 frozen embryos is excellent, and should confer hopefully a good chance of pregnancy, as long as we can optimize that the uterus. That being said, even in the absence of fibroids, there may be issues with thickening of the lining of the uterus, and there are different things that can be done. In addition to giving support with things like estrogen, there's vitamin E, and vaginal Viagra are sort of the two primary go-tos.
Okay. Well, that is awesome, awesome information. We've taken about an hour of your time, but you have again supplied us with a wealth of information. So again, everyone can find you again in the New York office. of Shady Grove Fertility. That's shadygrovefertility.com.
Soon to be in Brooklyn too.
Soon to be in Brooklyn too. Okay. Is there anywhere else they can find you? Do you know? Are we on Instagram? I say we. Are you guys on Instagram? Are you on Instagram?
Shady Grove is on. Yes, Shady Grove is on Instagram. The best way though is definitely through the website. It has direct links, and we'll give you the numbers to give a call. But yeah, so I would say the website is the best place.
Okay. All right. Well, thank you so much for joining us again
Thank
this
you.
evening. I know you've got a crazy schedule with the kids and your wife, but again, thank you for taking the time to speak with us. And we will definitely keep you posted. And hopefully, anyone who's in the New York area, please feel free to check out Dr. Setton and give him a call or give him a visit. And thank you again for visiting with us.
Thank you very much for having me. It really was a pleasure.
Same here. Good evening.
Have a good evening.